Good evening. Thank you for joining us for our Asthma Management Changes and Environmental Impact webinar. My name is Phoebe James, and I'm a Professional Development Officer with the Hunter New England and Central Coast Primary Health Network. Before we begin, I would like to acknowledge the traditional custodians of the land I live and work on, and pay my respects to elders past, present, and any First Nations people joining us this evening. I just wanted to mention this session is being recorded. The recording and the PDF of the slides will be available in the Education Library on the PHN website in the next week or so. At the end of this presentation, we'll have a Q&A session. Please put your questions in the chat, and if we have time, we will cover them. We have Denise Lyons here from our Health Pathways team, and she will be running us through the relevant pathways which relate to the presentation, which will be great. It is now my pleasure to introduce John Harrington, Respiratory Nurse Consultant at John Hunter Hospital. I'll now hand over to John.
Thank you, Phoebe, very much. I hope everyone can hear me fine. And I'd just like to extend my thanks to Phoebe, Denise, and Sandra and all the PHN team that gave me the opportunity to talk to you today about updates to asthma management guidelines, and also to incorporate some information on the environmental impact of asthma treatment. I too would like to acknowledge the traditional owners of the land on which I'm on, which is the Awabakal people, and like to pay my respects to elders past, present and emerging, and also highlight that respiratory disease affects First Nation people at greater prevalence and worse outcomes. More needs to be done to close the gap. These are my disclosures. The only ones that are relevant to this presentation is that I'm not a subject matter expert for pediatrics, so any pediatric information that I go through with you today will just be recycling the information from the guidelines, and I'm not well placed to answer any questions on pediatric clinical management. And probably more pertinent is that I only finished my slides today in the middle of a power output, and I don't use AI, so you might be in for a bit of a rough ride with my information today. So apologies in advance for that. So our objectives today are to understand disease burden of asthma and the landscape of asthma in Australia, the current management of asthma in Australia, and where some key gaps might be, updates to the national asthma management pathways in paediatric, adolescent, adult groups, and to really highlight some of those important changes, including MART therapy and air therapy, which I'll go into in a bit more detail, and also to identify some of the supports to assist implementing asthma management in a gold standard approach. And finally, to explore some of the environmental sustainability considerations when we in our treatment of asthma in Australia. So just to start with some definition information, I think the audience is probably going to be very, very aware of asthma. It's a really common chronic disease. It's well known in the community by consumers and patients and carers. And the important things to highlight in the definition on the screen there is that they're variable respiratory symptoms, so such as wheeze, breathless, chest tightness and cough, and people have different dominant respiratory symptoms, and the other variable factor of airflow limitation. So the diagnosis of asthma in adults and adolescents is based on the symptoms and the presentation of those symptoms over time in frequency and severity, and objectively by the measurement of airflow limitation and response to bronchodilator treatment, which I'll go into more details shortly. So the burden of asthma in Australia is significant. As we've mentioned before, 11% of Australians have asthma. That equates to around 2.8 million people. This is as of 2024. In terms of chronic disease burden, it's 2.5% of all disease burden, and and asthma makes up 35% of respiratory conditioned disease burden. It's very prevalent in children, has high impact in children. It's the leading cause of hospital admissions in children, last time I checked, and it's the leading cause of disease burden in children aged under 10 years. It's a high cost disease, $1.2 billion Australian dollars per year, last time we counted. It's been nearly 10 years since we've done an economic analysis of asthma burden in Australia. These two tables on your screen, from a IHW website, the one on the left here I've included, because it pertains to some of the inequalities in the demographics of asthma. Up the top, you see the breakup by sex of asthma in Australia, with more females than males having asthma. That's overall in children. It's more common in males, but as a substantial proportion of children go into a quiescence or remission, you see females becoming the far more common sex presenting with asthma after puberty sets in. And in the bar graph below, Indigenous Australians are represented in categories of age group by the blue bars, and you can see in every single age group, in First Nation people are more likely to have asthma, and almost double the rate of asthma if you look at over 55s. On the right of the screen is a table of most common chronic diseases to be seen in GP clinics. In males, it is asthma coming in third. In females, it's third. Overall, it's third, and it's a big distance second to diabetes and osteoporosis. So it's a common cause for people to present to their primary care providers. Now, it's fair to say that a lot of asthma in Australia would be categorised as mild to possibly moderate. So when we count that, it's around half to 3/4 of asthma in Australia is designated somewhat, roughly, to being mild to moderate. Now, mild to moderate is either or low symptom burden or low risk of exacerbation, and that risk is developed on a history of exacerbation, previous exacerbations, and the severity of those exacerbations, or attacks as patient prefers. But when you drill into these figures a little bit more and the data a little bit more, you see that only a quarter of these mild to moderate asthma actually have signs of poorly controlled asthma. Nearly 20% of them have had to adjust their medications in the past to manage worsening symptoms. And somewhat worryingly, that of deaths from asthma-related deaths when they've been investigated, that people have been categorised as mild asthma and have still had a death that's been related to asthma. Now, these figures are international, not necessarily Australian, but I have some data on that Australian sort of severity in a short while. Just yesterday, the NAC sent out its press notice of the latest asthma mortality data via the ABS. Somewhat concerningly, we see that there's almost no change in asthma mortality from 2023-2024, with 478 deaths recorded, all mostly in the more populous states. There's some inequalities with that data as well, with 322 females dying from asthma-related death compared to 156, sadly. And I think it's worth considering that 478 deaths is a tragedy. The national road toll is only around 1,200 people. And we see that in the news a lot and is recorded constantly. So there's somewhat, I wonder about the perception of asthma being a dangerous disease in terms of death. Professor Walk, in responding in commentary to this data, has said that these tragic deaths reinforce the need for a correct diagnosis and proper anti-inflammatory treatment that's based on inhaled corticosteroids. If anyone caught Debbie Rigby's introduction to the Asthma Australia Handbook a few weeks back in September, her statement that she believes that no one should actually die from asthma with the treatments available today, which is quite a challenge to all of us involved in healthcare. The Asthma Australia Handbook that I just referenced is developed by the National Asthma Council of Australia. This is the third iteration we're up to, and this information is going to be guiding a lot of the talk going forward. It's a very easy to use resource. It's well laid out. And it's designed for online use, so it's thoroughly searchable. It's got linked documentation, so based on most likely the next topic that you need to go to. It's quite easy to use, and it's expert panel who developed it, world leaders in asthma care and treatment, and it was multidisciplinary and well represented. So delving into the Asthma Australia Handbook, I'm going to be showing slides of changes largely. And I my natural landing spot and where to start was some of the more objective or technical topics. And so I wanted to start with asthma diagnosis criteria, the objective diagnosis of asthma. So on this flowchart that I've taken directly out of the Asthma Australia Handbook, you'll see at the top someone's presenting for examination, and they give a history of variable respiratory symptoms. Your history and physical examination confirm this, and if there's markers of high risk or concern or severity of symptoms, that you can start treatment before going down an objective diagnostic route, which is in this box below here. And the spirometry criteria for diagnosing asthma hasn't changed from previous iterations of the Asthma Australian Handbook. Now, that's somewhat interesting, which I'll come back to. What is new has been included is FeNO. The spirometry bronchodilator reversibility criteria, as per the Asthma Australian Handbook, is still an FEV1 increase of equal or greater than 12% and equal or greater than 200 mil. Now, the American Thoracic Society and the European Respiratory Society, who give the international guidelines for lung function testing and spirometry, they've updated their bronchodilator reversibility guidance to be 10%, and that 10% is compared to the normal values of someone that age, height, and sex. It lowers some of the statistical variance around the lower limit of normal and reduces the Z-score. So statistically, it's just a tweak. But you need to use a certain normal set of values. That's the Global Lung Initiative. This guidance is keeping it simple and keeping it old school. When comparing whether there's a difference in most patients, those two differences in bronchodilator reversibility, you do not usually include or exclude many people at all. FeNO is a test that measures expired gas in the lungs and airway, and also sinonasal cavity, if you wanted to measure that. And it stands for the fraction of expired nitric oxide. And that nitric oxide is a byproduct of certain inflammation in the airway. It's a portable test. It can be done relatively easily. It's not a maximal test like spirometry. You just breathe out for a certain amount of time through a machine, and it gives you a number. And the cutoff for the Asthma Australian Handbook guidance is 40 parts per billion. Now, if it's yes to either, so if either you have bronchodilator reversibility or you have raised FeNO, then an asthma diagnosis is confirmed. If not, the guidance is to consider different diagnosis, consider referral to specialist, or through a pulmonary function lab, access a bronchial provocation test or bronchial challenge test. And those are tests where we stimulate airway hyperresponsiveness or airway constriction by giving agents that cause usually the airway lumen to dry out and cause mast cell degranulation and inflammatory activators to actually activate. In research world, we will often accept peak flow variability. Asthma Australia Handbook feels that that's not robust enough for standard diagnosis. And we also sometimes take FEV1 variability over time or to treatment, so systemic corticosteroids, and also we also include increase in FVC as well of 12% or 200 mils and or 200 mils, but they want to keep it simple with the Asthma Australia Handbook. Now, some commentary on those tests. On the screen in front of you, see on the left-hand side some data that was prepared by Kerry Hancock in Adelaide, a GP with a fairly heavy presence in respiratory and highly valuable input. She's compiled MBS data on spirometry reimbursements. Unsurprisingly, in the big dip, here's is Q2 of 2020 when the COVID-19 pandemic hit and more or less shuttered all spirometry in Australia, not just GP practice spirometry. What's somewhat worrying is now these data run to 2022, end of 22, and we've not seen much of an increase in spirometry as to the level that it was being done at the end of 2019 or mid-2019. Um, I would say that spirometry is perfectly capable to be done in primary care in any settings. It's well established to be safe and fairly straightforward to do. The machines aren't horrendously expensive, and their test costs aren't very high. So there are resources coming out and a bit more oomph being put behind spirometry across Australia with some various representative bodies. So I hope in the coming months to years we'll see that that curve go up a bit. On the right of your screen is an example of a pheno machine. Now, pheno machines themselves can be a little bit expensive. The one on the screen's around $5,000 to $8,000. I'm not sure exactly the price. It has changed a bit with different companies marketing them in Australia. This device actually has a fairly decent per test cost because the sensor is only is limited to a certain amount of tests and has to be replaced as the handle. There's also other caveats with the test. It's parts per billion, so it's very small numbers. It is sensitive, but somewhat not specific. It is worth pointing out that nitric oxide is a byproduct of interleukin-13 activity, so it's quite a specific form of inflammation. We would designate that as T2 high inflammation. If you don't have T2 high inflammation, you might not score a very high pheno reading. If you do pheno after spirometry, the pheno levels will be artificially lowered by high volume breathing. Carbonated drinks, smoking can suppress the pheno value itself. It's important to note as well, inhaled corticosteroids will dampen T2 inflammation and therefore lower the pheno result as well. So we sometimes use pheno as a marker of potential adherence to inhaled corticosteroids as well, but it has to be done fairly carefully because they might have inhaled corticosteroid resistance. So some issues with pheno, somewhat costly, not as commonly used as say spirometry in the GP practices. Asthma management goals highlight this before we sort of move on to some more details about asthma in Australia. It should be quite obvious that we want to have the best outcome for our patients. We want to make sure that they have control of their chronic disease. Asthma can be controlled. We want to make sure that they've got no unimpaired physical activity, next to no asthma symptoms by various markers, and sleep disturbance is quite a concern, and it's quite a bad marker of poor asthma control when sleep is disturbed by asthma. We also want to reduce risk of exacerbations and death, and we want to see no attacks, no oral corticosteroids, stable lung function or possibly improved depending on when they start treatment. And we also want to see that there's no medication side effects from the treatments that we initiate. Now, earlier on, I did show a slide stating that 50 to 75% of asthma is mild. But I'd like to draw your attention to some these data that Helen Riddell from RPA presented back in 2015 in the MGA, and has followed this up late in 2020. And this is a phone survey of 2,700 odd participants. They're adults-ish, over 16 years of age. And this pie graph designates these people into well-controlled with no preventer or not taking a preventer, well-controlled taking their preventer regularly, that's part wedge B, uncontrolled and taking a preventer regularly, or uncontrolled with no preventer or poor adherence. And it's kind of worth noting that if you put the poor adherence or no preventer together, it makes up the significant proportion of these patients. I'd highlighted on the screen the people that I was really, really worried about, those that have uncontrolled symptoms with or without preventer. But it shows that there's a substantial amount of patients in Australia that are being managed without a anti-inflammatory treatment or preventer treatment. Now, most of these people will be trying to manage their asthma with the blue puffer on the right of your screen. So albuterol in America. It's widely available in Australia. It's an across-the-counter medication. It's the most common asthma treatment worldwide, and that's largely because it works. It's for most people. It's quite a an active drug, and but it only works temporarily as a reliever. We refer to it as a SABA, short-acting beta agonist, and it's been recognised as quite a concern of overuse and risky treatment for decades. And I took that quote from a 1990 article that was talking about the risk of being known of this medication for decades, and that was published over 30 years ago now. This table, forest plot graph in front of you, is from Bateman in the European Respiratory Journal, further highlighting our concerns about short-acting beta agonist use and risk. The forest plot A is referring to the incidence rate ratio of having a severe asthma exacerbation. That's an exacerbation that leads to ED treatment or inpatient admission. And on the y-axis, we're seeing the risk ratio, and the x-axis showing the number of SABA canisters. So if you're using 13 or more canisters in a 12-month period, you nearly double the risk of a admission for asthma exacerbation than someone who uses 1 to 2 in a year. And it was a substantial amount of people that they recruited into the study, over 4,600 of them. On the right, you've got the odds ratio of having well-controlled asthma as per the same canister usage criteria. So you've only got about a 33% chance of having your asthma well controlled if you're using 13 or more blue inhalers a year. So not only are you at higher risk of exacerbation and hospitalization, you're also at much lower risk of having your asthma well controlled. These data is not new. These two graphs are pretty famous in asthma world. The graph on the left is from the American Journal of Respiratory Critical Care Medicine, the Blue Journal, seeing asthma deaths per 10,000 patients compared to canister units, so 200 dose SABA, so that's our standard Ventolin reliever. It increases dramatically, especially as we go over 4 canisters per month. On the right of the screen is another Sami Sissa graph showing that the use of ICS and canisters per year compared to rate ratio of death from asthma. And you can see, even using 6, your rate ratio is reduced nearly fivefold. So even on our standard prescriptions for regular ICS use would be 12 a year, 1 a month. So even if you only get half the amount of ICS use, you will have a fivefold reduction in mortality from asthma. And we know that if you use 6 inhalations a day of SABA, that you've got a much higher risk of severe exacerbation in the following 21 days. So there's a time issue as well with that. Not only are we worried about exacerbations and death, a nice study from Louisa Au in Northern Europe showed that SABA overuse is also related to higher smoking rates, higher BMI, lower FEV1, and also higher bronchodilator reversibility as percentage change. Interestingly, for me as a monoclonal antibody nerd, these patients also had a higher sputum eosinophil count, which probably relates to that T2 high inflammation I mentioned previously when talking about FeNO. T2 high asthma has been well documented to be a higher risk asthma. You have more risk of exacerbations and more risk of severity of exacerbations. So the people who have eosinophilic asthma as a phenotype are often SABA overusers. So we've been worried about SABA for a long time, and we've got good reasons for being worried about SABA. Now, it is somewhat of a surprise in our old Asthma Australian Handbook that there was a little square down the bottom, starting at 1 in the stepwise process, that a few patients could get as needed SABA alone. Now, we've gone beyond that now. We've aligned to the international guidelines to say that this little subsection is no longer something we want to see, and we've updated what is often fondly referred to as the ziggurat of asthma care to now having a starting point of 1 here, where the recommendation is to go with a budesonide formoterol preparation, low dose as needed. So they don't have a blue puffer. They have a single ICS LABA, so inhaled corticosteroid long-acting beta agonist, low-dose puffer that they can use when their symptoms drive them to use it. You can also consider putting them on a low-dose inhaled corticosteroid, so standalone inhaled corticosteroid, plus a SABA reliever as needed, though that would be 2 different puffers compared to 1. There is subsequent steps up. We see ICS formoterol. So instead of budesonide, we now have a general inhaled corticosteroid plus the long-acting beta agonist of formoterol as maintenance and reliever therapy. This is called MART. So they're having it regularly. The usual dose is 2 puffs in the afternoon and night, in the morning and night, and then they can have extra reliever doses of the same preparation, so a single reliever and preventer. Alternatively, the same level of treatment that can be offered is a combined inhaled corticosteroid LABA option plus a short-acting beta agonist reliever. So again, it's 2 versus 1. And then the next step up is a medium dose ICS formoterol MART, maintenance and reliever therapy, or medium dose ICS LABA plus SABA as needed. So you've just stepped up a dose here from low dose to medium dose. Beyond this, the recommendation is referral to a specialist review for targeted intensive treatment. We will also, in our specialist units, go back over all the steps previously to make sure that everything's been done to the level that is required to be. Whilst waiting for that referral to occur, there is the opportunity to consider a third controller like a LAMA or a trial of a high-dose ICS LABA. So there's some options that can be considered whilst the patient's waiting to be seen by a specialist review, and it's probably the first step we'd undertake if it hadn't been done so in our clinic. The Asthma Australia Handbook has also rationalised its classification of asthma symptom control. Previously, they did have an intermediate, so between core good control and poor control. They had an intermediate response table, but they've simplified that, and I think that's for the better. So good control would be manifest by over the past month having less than 2 or less symptoms of asthma during the daytime per week, no limitation of activity, no waking at night, and only using their reliever 2 or less days in a week. So that's one occasion counts as one of those uses. Poor control is the opposite of that. So daytime symptoms greater than 2 times a week, any limitation, any night awakening, and reliever use more than 2 days a week. Now, we don't take reliever use when people as counted when they use prophylactically before exercise. And when someone's using a budesonide formoterol reliever therapy, we're not including that either. So it's those are not counting that. We also take into account baseline lung function, level of asthma symptom control, and that can be tested through things like an asthma control score or the asthma control questionnaire. And if there's factors of high risk like previous ICU admissions, decline in lung function, or any problems with treatment that's been tried before, then these are taken into account and probably push people to refer to a specialist centre, hopefully. So if we look at that first step a bit more in detail, the budesonide formoterol as anti-reliever therapy, or AIR, or ICS and SABA, but I'll concentrate on AIR because AIR is a kind of a new phenomenon. The data for AIR is pretty substantial. With the Beasley study in 2019 showed a significant reduction in exacerbations. That's shown in the middle graph. So compared to SABA alone and budesonide maintenance group and budesonide formoterol group. So we're seeing quite a substantial reduction in the budesonide groups, both with budesonide maintenance and budesonide as needed compared to reliever only. And when they looked at the hazard ratios for time to exacerbation over quite a long time, approaching 500 days, interestingly enough, I found this quite interesting. It's budesonide maintenance and the albuterol treatment arms were pretty close in terms of their hazard ratios, and they weren't statistically significant. And it was only the air group that had any sort of a difference in exacerbation risk over quite a long, over a long time frame. It gets a bit confusing when we start thinking about inhalers, though. There's a lot of different inhalers. I think last time I counted, there was around 40 different inhalers for COPD and asthma available. And it can be difficult to know which one to pick and which one can be used for which purposes. On the left of your screen is a table out of the treatment information on the Asthma Australia Handbook that lists the different type of inhalers that can be used for air, their dosage, and their maximum inhalations in a 24-hour period, and the age restrictions with them. So it's not just the well-known Symbicort, for example. Relast is available, Bufomix as well, and Durarest Spiromax are also available for air. And on the NAC wall chart, which is a great resource, can be ordered directly from the National Asthma Council, is also downloadable as a PDF online free of charge. If you look carefully, you might see some letters designated with a black circle, A and M, or M alone. Those are designating whether this inhaler can be used for air, and for the A, and M for the MART. So you can see the Symbicort low dose air, and for MART as well, Bufomix there in the dry powder inhaler, Duoresp in the dry powder inhaler. So they're designated that can be used for those. You can see that, say, the Seretide inhaler is not authorised and not recommended for anything but ICS, LABA, regular dosing plus SABA. So it can be helpful to sort of put this into a case, a patient scenario to understand the sort of the application for it. And I'll introduce Dave, who's a 41-year-old PE teacher. He's got no medical history. He got a virus that was going around the school, and he's come to his complaining of some shortness of breath, and he got some Ventolin from the pharmacy, and he felt it helped him a bit. His symptoms are cough and breathlessness. Notices there's weather changes with that. He's got a bit of allergy, a bit of seasonal hay fever, no family history. Listening to his lungs, he's got a widespread wheeze. He's a non-smoker. He takes the across-the-counter salbutamol, a bit of paracetamol, a bit of nasal decongestant, the odd little throat lozenge. So all very low-level stuff. When we send him off for spirometry, we can see that his FEV1 is reduced. His FEV1 compared to FVC is in an obstructed ratio, low or limited normal approach at 70%. And we can see that there's a fairly significant change between pre and post bronchodilator. So it works out to around 30% increase and well over 200 mils. It's just over 100 mils in total. A litre. So he's got a litre increase in his bronchodilator reversibility FEV1. His FeNO test has got 67 parts per billion. Now, going on our previously shown diagnostic criteria, that satisfies both high FeNO for marker of inflammation and bronchodilator reversibility. So we followed the guidelines. There was not a big significant risk factor for him. He hadn't been hospitalised previously. No, their symptoms were intermittent and not very persistent and not very severe. So prescribed him a budesonide formoterol inhaler to take as needed, and to follow up in 3 to 6 months to see how it's going, and with advice to come back and see sooner if unwell. Unfortunately, when David comes back to see you, he's had an exacerbation requiring ED attendance and treatment, and he was treated with oral corticosteroids in ED and discharged out, which is a bit of a failure in treatment. And now is at a higher risk of exacerbation, severe exacerbation from just the exacerbation in ED treatment alone. His symptoms have worsened. He's now waking at night. He's got activity limitation in the last 2 weeks. His asthma control questionnaire score, mean score was 3.2. Anything above 1.5 is uncontrolled. He's missed some days of work, and he's using a reliever most days. So if we were following our Asthma Australia handbook guidance, we'd probably just jump to step 2 and say, well, he probably needs to increase his treatment to ICS formoterol as maintenance reliever, or a regular low dose ICS maintenance with SABA. But he's been in ED, so he might need to go to medium dose. It's a good debate. However, when we get Dave off his mobile phone, he tells you that he doesn't like taking the Symbicort you prescribed because he's worried about the cortisone in the inhaler. He thought it would make him gain weight. So, and he didn't feel it was working that well anyway. He felt the blue puffer worked better in the past. Some further questioning, you find that he's got a hoarse voice, frequent hoarse voice. He doesn't like perfume smells or petrol fumes because it make him suddenly short of breath. So it's worth pointing out on our Ziggurat treatment that there's a box that states before stepping up, we need to check that the symptoms are related to asthma, they're using their inhaler, and their technique is correct. So when we prescribe inhalers and when we see our patients, we should always be checking their symptoms, and also checking their adherence and their inhaler technique, and adjusting these as we find them, as well as taking stock of his symptoms, comorbidities, lung function, inflammatory biomarkers, and sometimes things like bone mineral density or blood glucose if they've been steroid exposed. Adherence is a very common issue with respiratory medications, and all medications, for example. The table on your screen is a summary of some of the well-known adherence studies with inhaled medications, inhaled corticosteroid medications, and asthma. And the center row shows the average adherence, and you can see that there's only one study that goes above 60%, and the usual expectation is that only around 50% of people are adherent, and our marker for adherence is taking 80% of the prescribed doses. Now, it's nice that anti-inflammatory reliever therapy does sidestep this issue to a degree because the patients are driven by their symptoms to take adherence, but it still needs to be assessed when we review the patients. If we were going to increase to a MART therapy or SMART therapy, if we allow for a Symbicort S at the front of that, again, that could be confusing. So the Asthma Australia Handbook has a nice table of all the MART therapy options. There's a fair few of them there listed on the table on the left, and there's a substantial amount of evidence for MART therapy as a successful treatment for asthma, with the meta-analysis table on the right of your screen with forest plot showing decently favours treatment and reduces risk of exacerbation. So MART is quite a legitimate treatment. It's I do tell the patients that it can be cheaper. MART therapy can be cheaper if their symptoms are well controlled. If they're not well controlled, it can be more expensive than, say, a regular inhaler plus a SABA inhaler. That kind of sort of irons out. It outweighs the 2 inhalers versus 1 if they're using a lot of the MART inhaler. If we go towards the top of our Ziggurat, we see that step 3 is medium dose MART therapy, and the table on the previous slide that I showed gives you the doses and the preparations that can be used for that, or medium dose ICS LABA regularly plus SABA. Now, previous guidance suggested that another step above this could be high dose ICS LABA plus SABA as a treatment option. The Asthma Australia Handbook is looking at encouraging people to refer prior to initiating high dose ICS LABA, that can be done whilst the patient's waiting to be seen in a specialist centre. In our centre, someone like Dave, we'd probably look at assessment for monoclonal antibody therapy, look at other add-on therapies like azithromycin, which can be used as an off-label treatment for severe asthma. And we'd probably get him to see one of our speech pathologists, taking into account his history of voice changes plus sudden triggers to strong smells. That can be an indicator for VCD/ILO. So I'm going to take a little jump across to a little bit jarringly, probably, to look at the paediatric guidance and start with children looking at children 6 to 11 years. As stated at the outset, I'm not going to go into too much depth of the paediatric changes, but I'll just point out that age 6 to 11, spirometry is still required for an asthma diagnosis. They're taking a cutoff of a 10% increase in FEV1, smaller lungs, smaller changes, and also a lower FeNO threshold of 25 parts per billion as the markers for inclusion of asthma diagnosis. The other factors are all the same as the adult flowchart, adolescent adult flowchart I showed earlier. It's a bit more complicated with children under the age of 5. They're not very good at doing spirometry, not very good at doing anything you tell them. So there's quite a detailed algorithmic process to go through before reaching a potential likely asthma diagnosis. And I don't think many people diagnosing asthma in those under 5 are super confident of that diagnosis until they're able to do spirometry, but treatment is usually initiated. For these children groups, you'll see in treatments that 6 to 11, that a starting point is using a blue puffer. The evidence is not there to use anti-inflammatory reliever therapy in children under the age of 12. It's only in those over 12 years of age, whereas the evidence on salbutamol for safety for children is pretty profound. The next step, if there are still symptoms present, then to start low-dose ICS alone and salbutamol is needed, and then it's a step up for if symptoms are still present, exacerbations are still occurring, to go to ICS LABA maintenance, low dose, or ICS medium dose plus salbutamol, and then to increase the medium dose plus salbutamol before a specialist referral. Slightly different there. And for children under the age of 6 years of age, it's a little bit more similar, but without the LABA involved. We've got salbutamol step 1, then ICS low dose plus salbutamol step 2, regular ICS medium dose plus salbutamol step 3 before referring to specialist management at that point. So with the last sort of 5 minutes, I'd like to jump completely across to a different topic altogether, but it's somewhat related, is asthma management and how it relates to the environment. Now, Dave comes back to you and says he's worried about damaging the environment with his asthma treatment. That's what he's been looking at on his phone the whole time. So what should we actually tell Dave? Well, it's pretty complicated, to be honest. So all healthcare provision, just like nearly every activity of humankind, has a carbon footprint. Healthcare is quite high carbon footprints. It's quite resource intensive. These could be examples of healthcare workers and patients travelling to work or their appointments, hospitalizations requiring resources to treat patients, electricity generation, etc. And we know that globally healthcare is responsible for around 4.4 of greenhouse gas emissions. Though if you look at higher OECD countries, you'll see that GHG is much higher, 7% in Australia, it's higher in the US, higher in the UK from memory. So they're fairly substantial greenhouse gas emissions as a proportion. One of the big issues is metered dose inhalers. They take up a decent proportion of that healthcare greenhouse gas emission. We haven't calculated in Australia the actual amount, as far as I'm aware. The UK ascertained that around 5% of all healthcare greenhouse gas emissions was actually because of metered dose inhalers. How has this happened? Well, metered dose inhalers were originally filled with propellant of chlorofluorocarbons, and people as old as me might remember that there was quite a significant hole in the ozone layer over the top of Australia that was caused by these chlorofluorocarbons. So MDIs have been on the bad side of the environment in the past. They were phased out in the 1987 Montreal Protocol, and they were replaced with hydrofluorocarbons, or HFCs. And at the same time, this idea that propellants might be the problem also led to the development of dry powder inhalers. Now, dry powder inhalers use a carrier powder commonly it's milk powder. The medication is, the active ingredient medication is made into a solution. It's sprayed on the milk powder, dried, they're put into capsules, and those capsules are put in inhaler devices automatically as you activate them, or as capsules, and then you punch the holes in them and you breathe in that powder, and the medication is absorbed through the airway lumen. So, but MDIs did proceed to be produced. They were quite popular. Puffers are still one of the more popular types of inhaled medication devices. Whilst the hydrofluorocarbons, HFCs, are not ozone depleting, they're quite significant greenhouse gas agents. And the bulk of the greenhouse gas is actually from its actual use in the release of the propellant and the drug, as you can see by the pie graph that I've taken from the TZAN's position statement on inhalers and carbon footprinting. Now, all HFCs are not the same. They have quite significant global warming potential. Some devices, 50 grams of CO2 equivalent, up to 300 grams of CO2 equivalent per actuation. And this works out to about nearly 10,000 to 36,000 grams of CO2 per device. So it's fairly significant. Once those are made, those devices, it doesn't matter if they're never used, those canisters will break down in the environment and those gases will be released eventually. So once they're produced, they're counted towards the greenhouse gas footprint. So that carbon footprint can be fairly significant, but when we compare it to dry powder, or the SMI is soft mist inhalers, those devices, dry powder and soft mist inhalers, can be 100, 200-fold times lower than that of the MDIs. In Australia, if we look at production dispensed of different types of inhalers, on the left-hand side in the bar graph, the MDI it far outweighs dry powder or soft mist inhalers. It's also worth pointing out that this only takes into account prescribed medications dispensed. So if you think about salbutamol being across the counter, they're not taken into account these data. And so the estimation is that MDI is probably 80% of inhaled devices sold in Australia compared to 20% of all the others. If you look at on the right side, the sort of the CO2 equivalent in grams from different inhaled devices, there's quite a significant spread on the MDI. But when you look at dry powder or soft mist inhaler, their CO2 equivalent, daily CO2 equivalent release are pretty homogeneous and much lower than when we look at the when we compare it to the MDI. And it's worth, as I said, some of those HFCs have got vastly different sort of greenhouse gas footprints. With HFC 134 it's got half the greenhouse gas potential of HFC 227. So, which is, it depends on which inhaler you use, really. This bar summary graph I've stolen from a British resource, so that's why it's in the distance is given in miles. It compares different types of inhalers to car journeys. So a 120 dose fluidiform or Symbicort inhaler is equivalent to a 115-mile petrol car journey, so about 200 to 250-kilometer car journey, and which is closely followed by salbutamol inhalers. Fairly significant greenhouse gas emission potential, with your soft mist dry powder being way down here in the very low kilogram of CO2 level. But it's not, so a strategy might be just to transfer everyone to dry powder or inhalers for asthma, but it's not that straightforward. And you'll often hear some of the experts in this arena saying that the best inhaler, the most environmentally friendly inhaler, is the one that the patient takes and it works for them. So this somewhat complex data that I've got on your screen here, I've taken it from Wilkinson's study of Sabina cohort, which is a really important study in asthma. That's the Sabina stands for SABA use in asthma study. So they're really big numbers, looking at over 1 million participants in the Sabina databases. And this analysis by Wilkinson looked at difference between well-controlled asthma carbon footprint and poorly controlled asthma carbon footprint. And up the top, you can see that CO2 tonnes in these green circles are vastly different, 12,000 versus 334,000 compared to these two groups. So the first group with 12,000, that's looking at the asthma cohort in the Sabina. They produced 12,000 CO2 tonnes equivalent. But the little light green strip at the top there, little segment, is the one that are well controlled. So the poorly controlled are making up substantial bulk of the greenhouse gas footprint. And when they extrapolate that out to asthma across the UK, they get that vastly larger figure of 334,000 tonnes of CO2. So if the inhaler's working and controlling people's asthma, their CO2 footprint will be much, much smaller. Down the bottom of the bar graphs, it's showing CO2 per capita emissions. And it's worth pointing out that by far in all of these groups, both in well-controlled and poorly controlled asthma, the biggest CO2 emitter by far was SARBA-related CO2. So that blue puffer is also a problem with environmental concerns. And so SARBA relievers accounted 94% of the per capita excessive emissions. And that's compared to exacerbations, compared to healthcare resource utilisation like clinics. So it's a fairly large contributor to greenhouse gas emissions. If we look at in more detail with some other greenhouse gas potential creators in the asthma world, in this bar graph, looking at exacerbations, inhaled corticosteroids, SARBA-related CO2 and routine healthcare resource utilisation in the all patients. In well-controlled, it's a bit closer to our ICS group in terms of carbon footprint, but it's still greater and significantly so. And then you see in poorly controlled asthma, there's a little bit increased exacerbation in healthcare resource utilisation, but not as much as you might have expected. And that dwarfs in comparison to the carbon footprint of the salbutamol inhalers. So it's not just down to prescribers to deal with this issue of greenhouse gas emission from inhalers. We look to industry and research development to move away from high GHG propellants, and that is underway. Currently, all the major inhaler device companies are about to release low greenhouse gas propellants. They're not as low as dry powder as far as I'm aware. I haven't seen the actual data on it yet, but that's what I've been told. But there will mean that it's not such a stark choice between dry powder and MDI in asthma. Industry needs to lower its greenhouse gas emissions in terms of production and transport. Regulators need to look at guidance and forcing manoeuvres to move people to low greenhouse gas treatments. Prescribers need to be aware of what the options are and to discuss these options with their patients. Pharmacies should be educating consumers on the need to take their inhalers, make sure people are aware that if they're using a lot of them, that they're probably having a higher greenhouse gas footprint. Consumers need to be aware of what they can do with recycling, which unfortunately is limited in Australia at the moment, certainly in New South Wales, and to adhere to their therapy. And to governments need to actually work to support these processes. On the right of your screen, I've taken this directly from the Royal Academy of GP guidance on inhalers and greenhouse gas emissions. And I'll just point out probably the most probably pertinent point here is consider this green one, which is being mindful that the greenest inhaler is the one the patient can use and will use, and then that we reassess that inhaler is working, and whatever MDI or dry powder, whatever gets the best symptom response and the lower exacerbations is the one that we should be promoting to our patients. So that's a whirlwind tour, and thank you for putting up with my chop and changes and somewhat halting delivery of all that information. These QR codes will take you to some of those resources we talked about here, the Asthma Australia handbooks on the left, and the PHN has done a lot of work to develop these guidelines and incorporate them into the treatment guidelines that are available on Community Health Pathways, and they're the other two QR codes. You will have to register to access those, and they're going to be they've been reviewed by subject matter experts, Dr. Tiemann and Dr. Matters, to name a few, and are now concordant with best practice guidelines. I'd like to thank you for listening to me tonight, and thank you to acknowledge my supporters and clinical colleagues at HMRI and at the John Hunter. Thank you very much.
Amazing. Thank you so much, John. That was jam-packed full of information. We will now hear from Denise while she sets herself up by sharing her screen. Oh, she's ready to go. Straight in. Before I throw over to you, Denise, I would just like to encourage people, if you do have any questions that you want answered, John obviously knows what he's talking about, so please feel free to put those into the chat box while Denise runs us through the health pathways. Thank you so much, Denise.
John obviously does know what he's talking about, and I just really want to owe you, we owe John a lot. He worked on about 6 iterations of translating the updated asthma handbook into usable health pathways format for us. So I just want to highlight here the health pathways that have been updated very, very recently with help from John and the whole asthma team, really, the pediatric respiratory specialists and an adult. So again, those QR codes will take you there. But also to highlight, there is further information on inhalers and techniques. And John talked about adherence and checking adherence. Really important. One thing I learned in Grand Round's talk a few weeks ago was how important it is to shake that inhaler. I think we all know it, but we really need to make sure people are actually doing it, making sure the medication's dispersed. But also, just in the cousins of asthma, cough in children and bronchiolitis in children are also health pathways that are available. I just want to really quickly, because I see what time it is, just show you some of the highlights, just reinforcing exactly what John just talked about and how that's reflected in the health pathways, to make it easy for you to navigate to what you need just on your desktop while you're got that patient with asthma in front of you and you're like, what did John say about escalating care? So just at the top of the pathway, is that showing up now, guys? The screen's visible? Yep.
Yes.
At the top of the pathway is going to be your link to the Australian Asthma Handbook, which is where all of this pathway is been translated from. So as per usual, we go through assessment. I'm not going to spend too much time. And John's key message from today, that all treatment levels include ICS now. And that's the hugest change in asthma management. We don't anymore use treatment based solely on as needed SABA in adults. Now, it is complicated, all those flow charts that John was showing us. So I just want to show you, if you skip on down in the management section to step number 4, it has information about choosing which inhaler you want to use, based on the patient's conditions and capabilities in terms of using the different inhalers. And then there's this little link to medications in a stepwise manner. And this is where you're going to find the descriptions kind of translated into words, showing you level 1. And then if you click again, you just have to click on these drop-down boxes and it's going to take you to the correct links. So level 1 is going to be that air therapy, anti-inflammatory reliever only. And if you want to know which medications are included in that, you can just click on that link and it'll take you to that table right in the handbook. And then it moves down to level 2 and the maintenance reliever therapy that John referred to, and on from there, all the way down to where we add in the llamas and refer to specialists. Also links just below. So if we close that, so sometimes it's hard to, people say it, sometimes it's hard to find things on here, but if you, for example, are on this page and you're saying, I really need a asthma action plan to give my patient, because all of our patients with asthma are going to have an asthma action plan. You can put asthma, you can, when you're on a page, do Control F, a little box, that's your find box, and you put asthma action plan. And it takes you right to where, so often people tell us they have trouble navigating through health pathways. And I just wanted to show you that little tip. If you click on that asthma action plan box, it'll give you links to the Asthma Council action plan library where you've got your, all of your customizable action plans. So hopefully you clinicians on the call will find the health pathway has been updated to make it easy for you to access all that really important, really new information about asthma management. Always at the bottom, By the way, if you're on the Central Coast, your pathway looks exactly the same. The only difference is going to be your referral options at the bottom. We're going to link to your referral options on the Central Coast as opposed to Hunter, New England. But yeah, there's always links down the bottom for health professionals. So all the guidelines and also patient resources. So to help you find the best resources to do your patient education and reinforcement and support with. So I'll be quiet to see if anybody else wants to speak. And thanks for giving me a minute, Tom, and John, and thanks again for all your help with getting this stuff up to date.
Amazing, Denise.
Right.
Thank you so much. We have had a couple of questions come through. If you're happy to answer them and wait around a little bit, we are just a little over time. John, why can't we use Symbicort 400 as smart? Why only 200?
There's a variety of reasons. I think the most important one is that it hasn't been studied as a treatment option in any large groups. There have been high dose inhaled corticosteroid studies done in the past, so it's not that we're concerned about that it's dangerous. It's not just that we haven't seen that it's actually improved anything. I think there's also sort of a philosophical question of like if inhaled corticosteroid is going to work, the way they work is that they work quite successfully at medium and low doses. And once they're not working at those doses, you can throw as much ICS as you want, and it tends to not really get much better benefit for it. 400 is a fair bit. If you start thinking about taking 1600 micrograms as regular ICS plus more on top of that as reliever, we'll start to see some systemic effects of systemic corticosteroid, like adrenal suppression and factors like that. So, and there's also a pneumonia risk of around 4 to 8% with our corticosteroid preparations that goes up if you increase the dose. So, it's not without some risk. So, if it's not working at a low dose and you upgrade to a medium dose and it's not working, it's probably worth considering regular high dose ICS and referral to a specialist centre. There's plenty of stuff written from the late 90s about ICS dosing. If you look up Richard Beasley, if you look at Sammy Swissar, those guys publish so much stuff about different doses. Paul O'Byrne from the UK, lots of wormhole stuff you can go into.
Amazing, thank you. And the last question that's come through, how do you see GPs, pharmacists and New South Wales Health working together to reduce SABA use and realise improved patient outcomes and decreased environmental footprints?
So that's a great question. And I think, first of all, like any problem, you have to acknowledge it first to really start to make any inroad on it. And it's not well broadcast in our respiratory circles that our treatments have issues with their sustainability. So I think, first of all, getting together as a group and saying there's a problem, and we're only it was only last year that we published a position paper from the Thoracic Society actually on this matter. So it's not just us local guys that are a bit slow to the party. It's Australia, New Zealand wide. There are some leaders in this area working on it. I think prescribers, like I said in my slide, been aware of that there's not just patient considerations, there's environmental considerations with their treatments, and that the treatment goal should be to stabilise the asthma so no reliever is needed, and to make sure that is really clearly stated. We as clinicians, we don't often go, this is what we want for you. We just listen to someone say, these are my problems, and go, I can do something about that. And so in our severe asthma group, we like to start with a discussion with the patient, what they want out of our relationship with us, and to sort of initiate some therapeutic goals together, and to state that, what we want is for low to no symptoms, no steroid exposures, no hospitalizations, higher activity, and controlled lung function, so lack of decline in lung function. But you talk about lung function with patients, and they're usually not particularly enamored by that. And we can marry that into that environmental sustainability paradigm of saying it's not just that we want this for you because it's good for you and it's good for long-term you, it's also good for the environment. And we don't add that bit on, and I think we should. Also, we could do better with recycling. Like the UK have done great stuff with recycling aluminium canisters from Saba and stuff like that, and we don't. We just let them degrade in landfill, and that's another problem. I go on and on about. Thanks, Phoebe.
Amazing. Thank you so much, John. You clearly live and breathe this topic. So thank you so much for spending your time and energy into this evening. It was jam-packed, really helpful to take us on the case study journey, the patient's journey, made it more practical. So thank you for putting that thought behind it. I want to thank all of our attendees for spending your evening with us. I have put a Slido in the chat. If you could just fill out the evaluation, I'll be forever grateful. Appreciating that we are cutting into your free time, family time, dinner time. So we do really appreciate you spending your evening with us. I may not see many of you before the Christmas break, so please make sure you're taking care of yourselves and you're celebrating safely. To the wonderful team that helped me put this together, Ellen, Health Pathways, all of you, thank you so much. John, you've been an absolute star. Look after yourselves. Thank you.
Thanks all. Have a great evening.